Perfect. So the time is 2 o'clock, and as usual, we begin today's session. So thank you everyone for joining in. Just type in the location from where you are tuning in. Bangalore, Delhi, which place? Which are the places you are tuning in? Bangalore, most of you are from Bangalore, Mumbai. Okay, different places. Any other places? Sholapur, Pune. Excellent. Bid, okay. Wow, that's good. Any other place? Excellent. So thank you everyone for tuning into today's session. And as usual, we begin today's session. Every Saturday we do this to create awareness about pharmacy profession and the professionals regarding various opportunities that exist in the domain today. So Vidya ma'am, if you are here, please log in and we'll begin.
Yes, sir.
Perfect. So we can't see you though. We can hear you. So let's welcome Dr. Vidya Tirumurthy, a wonderful pharmacy teacher and a mentor. Yes, ma'am, you are visible.
Yes, sir.
Thank you for tuning in. So Dr. Vidya has done her B.Pharm from Sri Ramakrishna College of Pharmacy, M.Pharm from JSS, one of the prestigious colleges in Ooty, and then PhD from JNTU, Hyderabad. She has many accolades of excellence ever since her graduation. She was awarded as the best faculty by the management of Alamein College of Pharmacy. She has published more than 20 plus articles in various international journals. She supports various international journals as a reviewer. She has also compiled books on research methodologies and clinical research for Karnataka Open University. She is currently professor, Department of Pharmacy practice at Alamein College of Pharmacy. She promotes clinical pharmacy and loves helping pharmacy students choose the right path of clinical practice. So that's why she's here. With this short intro, I now hand over the entire stage, the virtual stage, to Vidya ma'am. Please help us understand more about what you do and guide us what actually is clinical pharmacy all about.
So good afternoon, sir. Thanks for this invitation, Manoj sir. And good afternoon, one and all. A Saturday afternoon, a rest period, listening to a lecture. I can imagine. But I'll try my level best to make it more interesting, because we should support people who dedicates this much to improve our profession, like Manoj sir. So we should support it. And it is always happy to we teachers are committed to do that. But what you do is I can't describe it in words. Very good, sir. Hats off to you for arranging all these things. Okay. So a very good afternoon to one and all. So today's session would be on clinical pharmacy. So what is that, and what are the career opportunities we have? Because many of them has a myth, or many of them has a feeling. This is not my cup of tea, isn't it? Or not, clinical pharmacy is not my cup of tea. A clinical pharmacy is something like, still today you won't get job. It is when you don't get any M.Pharm degree, you go for pharmacy practice. That's all a myth, which is not there. So it is just opportunities are huge in front of you. You have to just take it up. Always hot and spicy biryani is there. It is we who have to just take it and enjoy that. So clinical pharmacy is one among like that. A masterpiece biryani it is, isn't it or not? So probably it can be interactive and all, because I know this webinar is little uncomfortable for teachers like us, because a classroom with a number of students are what we are very habituated, and that's the way we want our teaching also to be. But that fine webinar, since we can't connect a person from Assam, Pune, Mumbai, it's a very good platform to meet you all. So let me try my level best to make this as a non-sleepy session, because I know 2 o'clock is not the right time to have a theory. So I'll try my level best. So coming to the this one, I'm sharing my screen.
Yes, ma'am, please. We'll not allow the participants to sleep, ma'am. Don't worry. I'll be in the back end. I'll be putting them for chats, and we'll ask questions so that they are awake and they interact with us.
So hope all can see my screen here.
Absolutely. I can see
Yes.
participants just confirm, just type Y
Anyone
in the
please
chat box if
confirm?
you can see. Yes, the
Yeah.
slides are visible now. Perfect.
Well, so today talk would be on clinical pharmacy, a promising career opportunity. The word is not just to write a promising, it's really a promising career opportunity. So myself, the Vidya Tirumurthy. So I did my B Pharm from, as Sir was mentioning, from Ramakrishna College of Pharmacy, Coimbatore, one of the very reputed pharmacy college. So as every one of you knows, no one will have that, like I have to do my pharmacy, isn't it, Anand? So that was the same case. I tried for my MBBS, like I couldn't go for that. Then what is the next choice when it came? I don't want to go to Ayurveda, veterinary science and all. So then I felt like, okay, the other option I could go as a B Pharm. So that is how I have chosen B Pharm. And M Pharm I have done it especially in pharmacy practice specialization from the reputed institute JSS College of Pharmacy, Ooty. Though I took B Pharm with a, no choice because of MBBS, but it was my second B Pharm where I decided that my M Pharm should be only in pharmacy practice. That clarity I got it when I was doing my second B Pharm. My teacher, I'm very glad to tell him that Dr. Sriram from Ramakrishna, Coimbatore, every one of you must have heard, one of a pioneer in pharmacy practice field. Um, Always proud to be his student. So he used to come for teaching pharmacology for us. Okay, and he was taking care of the department pharmacy practice. I'm talking about in 1999, where the pharmacy practice are not much known outside. So, but that I decided that if I do my M.Pharm, my M.Pharm is only in pharmacy practice, only because of the way he narrates the drugs. So that was the, spark for me that I have to carry out on it. That's how I entered into M.Pharm, pharmacy practice exclusively. The interesting thing to be shared here is that was period where pharmacy practice people will take is only those who wants to go for abroad. Usually people from Kerala used to take because they go more to abroad. So usually only those people used to take M.Pharm pharmacy practice, are people who just wants to have in their marriage invitation on M.Pharm, they used to take pharmacy practice. Rest all people were running behind Sutix analysis and pharmacology. So when I got the rank of #1 in Tamil Nadu, and I asked the counseling people, I want pharmacy practice. People are you sure? Are you sure you have whole Tamil Nadu, all the colleges open for you, all the department are open for you? Are you sure you want pharmacy practice? I said, yes, I want only pharmacy practice. So everyone was shocked to hear that being with pharmacology or pharmaceutics, why am I behind pharmacy practice? I got that clarity, and I'm telling you, I will never regret for what I have chosen. Okay. So no need only until my death. I'm a proud pharmacy clinical, pharmacist. So that is where, and then I did my PhD from JNTU Hyderabad. I did it on cancer field. My domain was cancer therapy. So I did my this one. I pursued it almost 8 years. My PhD is because it was a part time. I got married, got my sons, and I got my PhD. So that is how part time I did my PhD. Started my career in Sahar institutions around 2007, and then I came to Alamin around 2012. 2012 on October 2nd, first I took charges, the in charge of the department, and by God's blessing, still today I'm here and I'm taking care of the department. So as I mentioned earlier, I'm proud that I'm a clinical pharmacist, and I always feel that this is the field that has to be taken to every corner of the country, because I can't say world it is already recognized, but in India, isn't it? So that's what just a very small intro to me. So coming to the core part of that, so I have some slide. So since it's not a classroom, I can't ask you. So there are 3 people in this. And what is the similarity with these 3 people is all the 3 are different captains, isn't it? I have Dhoni, and Dhanraj Pillai. So this is what is pharmacy is. Pharmacy doesn't mean that you have only one. You have hospital pharmacy, you have community pharmacy, you have clinical pharmacy. So you have some other types, but I'm just covering you only the generalized one. So you have broadly, you can divide them into hospital pharmacy, community pharmacy, and the clinical pharmacy. Don't ask me Dhoni belongs to which pharmacy. That is up to you to take it out. But this is what the pharmacy, this one. So if you see the three pharmacies, each has its own identity. That is why I have put three captains here. You can't compare a cricket with a hockey or with a football, isn't it? Everybody is master in their way they play or in their domain, what they are into. So in that way, if you take, each pharmacist has its own qualifications, own reputations, own job roles and responsibilities. So your hospital pharmacy is the backbone to run a hospital successfully, because you don't have a good inventory control, your medicines will not be dispensed properly. When your medications doesn't reach your patients properly, your feedback is big egg, isn't it? No one would come to you, isn't it? So that is what a hospital pharmacy, they play a key role in procuring, maintaining an inventory. So all these things, they work around 24 hours in the hospital, the pharmacist, isn't it? When you come to the community pharmacy, I can say they are the heart of the pharmacy. Or you can say they are the face of the pharmacy. No one knows a hospital pharmacist. No one knows about a clinical pharmacist. But you go, a community knows only a community pharmacist. And I always feels that the responsibilities of community pharmacists are still more than any other pharmacist, because direct contact with the patient's customer is only them. They are the representatives. And sorry to say that also we failed in that area. We should acknowledge that our mistake has happened, because how many of them respect the way they respect a physician? They just see us a person who's a grocery stop fellow, and we are same for a pharmacist. Who failed it? We failed to establish it. We started selling our certificates. We started selling our profession for 2,000 rupees and 3,000 rupees, and we surrendered our profession absolutely. So people, how many pharmacy we are seeing, there are absolute qualified pharmacists sitting and dispensing the drug. How many community pharmacists aware of what the drug he is dispensing has, what kind of drug interaction, has what kind of food interaction? How many people are this one? We are just fully seeing antibiotics are getting dispensed OTC without even a patient information. So we have a huge responsibility, though that area we have failed, but they are doing their job at least to some extent. I can't blame everybody. There are very good pharmacists, community pharmacists, because every year in Karnataka, we have the training system for our pharmacists, okay, hospital pharmacists. I teach at least 3 days when they schedule it about what are the responsibilities to hospital pharmacists as well as community pharmacists. I specifically take 2 to 3 classes every year to update them what is happening in our field, because they're not much aware of what is this ADR reporting, nothing. So that we are trying our level best even to keep them updated about our profession. Then the third field, clinical pharmacy. So it is a field that has direct patient care, and you want a satisfaction of your work, then you should work as a clinical pharmacist. I'm telling you. Other MPharm degrees, don't mistake me, but that is what it is. You need a satisfaction of your job profile. You have to be like a clinical pharmacist, and then you'll feel that yes, I have done something to my community, isn't it or not? So that is what your clinical pharmacy is. So though 3 fields are different, all has their own roles and responsibilities. Since we are emphasizing on CP more, I would love to go towards CP. Now comes, everywhere we hear pharmacy practice, clinical pharmacy, clinical this one. Is there a big difference between a pharmacy practice and a clinical pharmacy? Because you take the course in our country also, it is MPharm pharmacy practice, isn't it? It is written like that, isn't it or not? So it is a pharmacy practice field. So what is the difference if you ask in a layman word to tell me? No difference. Both sounds similar only. But what is the difference between this pharmacy practices, as I have written? It is an extensive discipline where clinical practice as well as the traditional form of pharmacy can be practiced. The reason is, you take a community pharmacy, hospital pharmacy, clinical pharmacy. All this pharmacy are practicing pharmacies. So these practicing pharmacies clubbed is what your pharmacy practice is. Your clinical pharmacy is entirely different. No, not different. It is one part of your pharmacy practice. Hospital, community, clinical, all comes under the term called as pharmacy practice. You practice your pharmacy. Who practice your pharmacy? Your hospital people practice by dispensing, your community practice by dispensing, your clinical practice. So that is why it is pharmacy practice. I have put a banyan tree because the tree is one, but it has a lot of branches. So pharmacy practice is like a banyan tree, which covers so many fields under it. So that is why we call it as pharmacy practice. Layman word, yes, CP and pharmacy practice are same, but pharmacy practice is like a banyan tree, which covers lot of fields into it. Yes, coming to our clinical pharmacy. Defined as that area of pharmacy concerned with the science and practice of rational medication use. If someone can tell me what is clinical pharmacy, answer me in one word, I'll tell rational drug use. That would be my answer for the question, rational drug use. These clinical pharmacy people ensures that the drugs are being used very, very rationally in the patients. Okay. In presence of a clinical pharmacist. If a clinical pharmacist is present in a hospital, no mistake should happen in terms with the drug used in the hospital. So that is the thing which is there with the clinical pharmacy. So it is a health discipline in which the pharmacist provide patient care, optimizes medication therapy, wellness, and disease prevention. So overall, as I was telling, it is just a rational medication use. You care your patient directly. So patient care is what your clinical pharmacy is. How we do what we do, we will see. But one word to say, it is a rational use so that you care your patient. Under your presence, you have to ensure that quality of life and safety of every single patient is maintained at your premises. So that is the first thing. And this is the mother of the beautiful word, pharmaceutical care. Pharmaceutical care is a broad term, but the mother of this pharmaceutical care is clinical pharmacy. It starts from, I can say, manufacturing of a good drug and ensure that the drug reaches to the patient in a safer way. So it is what a pharmaceutical care. Care starts from the scrap to a biggest building. So from the manufacturing of a drug until the drug reach and gives the efficacy or it shows its effect to the patient, whole care is taken care by the clinical pharmacy. So that is what our clinical pharmacy is. So hope everybody can see this and everybody can know this is a bamboo, isn't it, Anna? So why clinical pharmacy is a bamboo? I have put us, bamboo has a quality. When we immerse the seeds of bamboo or the cut of the bamboo, it will take quite long period to go as a plant or a tree. It takes a lot of period. People will think it is not growing, but that is how it grows. That is the nature of it. It goes inside first, then it comes outside. But once it comes outside, it grows like anything. Have you seen bamboo will be in clusters? It grows like anything. And you know what is the quality of the bamboo? Bamboo purifies everything. Bamboo purifies your air. Bamboo keeps your atmosphere very toxin free, very happy. You enjoy the breeze of a bamboo. It keeps you happy. That is what your clinical pharmacy is actually. It was not been identified by anybody. It was silently somewhere pressed out. Nobody was caring about it. The moment it started bloom, it have grown like a bamboo in our country. And it is giving such a smooth breeze to all the patients. So I can compare. I don't know to compare with anything else, because such a nature is what this bamboo is, and that is what our clinical pharmacy is. It is always proud to tell about our field, right? So that is what your clinical pharmacy is. You keep all the negativity, you keep all the side adverse effects away from your patients, and you provide a complete patient care for your patients, as like how a bamboo does, isn't it, Arnold? So that is why I have compared it. Coming to activities, what a clinical pharmacy the person can do, or a clinical pharmacist can do. If any of you are PharmD students, you would have studied this is all in your theory, isn't it, Anand? So we have to know that first, what am I capable of? I study 6 years of PharmD. I study 2 years of MPharm pharmacy practice. I pass my RGHS or MGR Medical University or any other related university. I pass that and come. But what am I supposed to do? Or what are my capabilities that I can do? Isn't it, Arnon? Here, what I would like to tell is 10 years, 11 years back, when we started the course of PharmD, even it was very difficult for us to convince our physicians that what should I do with your students? What should I do? What will they do for us? That is what every physician used to approach me. I used to wait hours together outside of every physician's chamber to address them. What is clinical pharmacy? How a hospital can get benefited if you have this department with you. To address this, I used to wait hours together. It was in 2011-12 scenario, I'm telling. So it was not easy to convince. No, I know about adverse effects. I know I'm 23 years practicing physician. I know how to prescribe. What do you want to comment on it? That was what people's opinion were towards it. But I'm telling you right now, scenario is different. Every physician comes and asks, could you place some student as a clinical pharmacist? Because I'm habituated with them from morning to evening. In clinic, it is tough for me without working, without having them with me. It is very tough. It is very tough. Could you just post some students with me? So this is what it is, a vice versa scenario today. They come, they ask me, could you please provide some internship student to me? Could you give that this? So that is what. So this all happens where we failed to exhibit what we can do. We forget to tell the society what is our real, like a capability, but what we have been focused of. We can do lot number of activities, but a community person still knows as a person of dispensing the drug. So it is a failure from our side to convey. And ourselves, we doesn't know what and all we can do, isn't it, Arnab? So the one point we can do enormous activities, but time constraint, I've just picked only very few activities. We do more activities than what I have mentioned here, but time constraint, I'm just emphasizing on important activities, what as a clinical pharmacist you can, practice. So first I wanted to tell you is medication error. This is 100% preventable area, but maximum it is not getting prevented, and that happens only because there is no clinical pharmacist present in the hospital. Can range from nothing to death. I'm not going in detail into that. We have certain classes how we are calculating them from nothing to death, but error can cause you without any effect. That reaction can go, or it can even cause a death for the patient. That is merely negligible, isn't it, Anand? So recklessness, people make mistake, but if at all a clinical pharmacist is there, this can get avoided. Consequences can be temporary or permanent, because that has happened. Either it can be a temporary or it can be a permanent change. Can occur at any stage of medication, from prescribing to handling and administering. So error, it is not that only one person can make. We are human beings. We are prone to do mistakes. But who? It can be anybody. A person who prescribes instead of 20 mg, if he is written 200 mg. So a thing can go wrong there, which we call it as prescription error. Is it or not? So you can have a handling by chance, you're dispensing. There are a lot of LASA drugs, look-alike and sound-alike drugs. So by mistake, if the pharmacist dispenses a wrong drug, so error can come from there. Then you have the administrative error, where I have written properly, drug has been dispensed properly, but I failed to administer it properly. For example, which has to get administered in the morning, I forget to administer. Or a drug that has been asked to stop. Okay, but you have a patient, the patient is taking, for example, injection furosemide. The most common adverse drug reaction is hypokalemia. So looking at the potassium value, oh God, potassium is coming down. And if the doctor has written stop the drug, if the nurse has not seen the prescription properly, and if she has given the Lasix again 40 mg, patient will again get hypokalemia, which is a threat. So that administration error can happen from nurse. So mistake can be from a physician, from a pharmacist, from a nurse. The question is not who do a mistake, but how to prevent this mistake to happen. So that is why this monitoring an error. You have a clinic or your own clinic, like you work in a hospital, or you wish to work in a hospital, ensure that this is one area where you can concentrate, so that 100% of the error can get prevented. And another biggest concern here is 50% of the error goes to ADR. I have given you an example here now with hypokalemia. If that would have been got stopped, the patient may not get the ADR of hypokalemia. So absolute preventable. So that is what I've written. All the medication errors are preventable because it is man-made mistake. So it is 100% preventable. We have a lot of errors, but only I'm concentrating on the major errors that happens in the hospital. Out of all the errors, the maximum errors comes from either the nurses or from the prescribers. Okay, they don't write the units properly. They may not write the dose properly. Or they may not calculate their histories properly and prescribe a drug. Or the nurse may not administer the drug properly. So all this will lead to a medication error, which is 100% completely preventable. So for example, in our hospital, we have very negligible amount of errors because all the family students, 1 year of family student are posted regularly in the wards to monitor. So here the system we have made is like every patient case sheet has to be gone through before they are getting administered, and the CP students should go through it and they should see, then only the nurses can administer. So this is bringing down the errors very, very, very negligible amount here. So what it is, when the errors are avoided, adverse drug reactions can get avoided, and the patient's safety is more here. So this is one area everybody can practice, which is easy. What you want is a knowledge on drugs. That's it is what needed is. Okay. ADR, actually my favorite area. I always wish it should be lesson number. It should be lesson number. Okay. Fifth leading cause of death. We don't take it, quite seriously. But this is a fifth leading cause of death in almost all the developed countries also. Because what you use is a drug, a chemical. It has its own property. There are properties which you have not seen them during their clinical trials. So you can't just completely trust a drug to be only doing good to you. It can do even unwanted things to you. So that is a fifth leading cause of death. As per AIMS, 22.3% of the in and out patients experience ADR. Absolutely true statement. 5.9% visits to the medical emergency department were drug related. What a big number it is. It's quite a big number, 5.9%, isn't it, Anand? They come only because they suffer from a disease. They were given with some drugs, and then they come back because the drug caused more problem than what a disease caused. Isn't it, Anand? How bad it is, isn't it? So that is a very important thing. In US, the incidence of ADR among hospitalist patients was found to be 6.7% with 0.3% fatal outcome. Such a warning it is. Isn't it, Anand? When you are under the direct vigilance with your doctors and you are under a healthcare team, yet you develop 6.7% of the ADR is a big thing. And point 3 is fatal in the sense it is again a concern for us. So this is one area where I always tells you have to be master in this. Why I will tell you, physicians, until it is a threat, they don't bother to monitor or report or document the ADR, isn't it? But no other professionals has a knowledge to do on it. I can't ask a nurse, you monitor ADR and get me, because their knowledge towards that is very, very less. But if you are a clinical pharmacist, or if you are a clinical pharmacy student, then you are the right person to monitor the ADR. Is it to only monitor the ADR, report it? No. How you can prevent should be the first choice over there. So you can suggest your physicians, sir, already the patient's GRBS is this much, but the patient has been asked to go ahead with the human act rapid of 8 or 12 units. Sir, if we go with that human act rapid, probably patient may develop hypoglycemia. Then you have to tell, then okay, he'll stop that insulin. He may go for a OHA or whatever. So preventability of ADR is equally important. Or there are certain circumstances based on the risk-benefit ratio. Some drug would have been prescribed. But you have to ensure that you follow that the moment the patient develops ADR, you take a concern. You take a step on it. Should I need to withdraw the drug? Should I need to reduce the dose of the drug? Or is there any counter drugs can be given for the ADR? Certain times what will happen, life-saving drugs, we know the drug has to be taken and we know that the drugs would cause some ADR. At that time, what we have to give a counter drug on. Isn't it? This is one area where I sincerely expect all the clinical pharmacy people to be a masterpiece in that. The reason is, it is not that no single physician will write in their prescription, this drug has caused this ADR. No one will write. So it is you. If you have the good knowledge with your pharmacotherapeutics, you can go, you can look into your prescriptions, you can watch out for the drugs, and you can see like how you have to monitor the ADR. The moment you find that patient had developed an ADR, immediately pass the message to the physician, sir, so and so number patient has developed this, so that the action can be taken. Drug can get withdrawn, dose can get reduced, or drug can get withheld for some period of time. So all this are there. So this area, I'm telling you, nobody has knowledge in this. Nurses doesn't study pharmacology the way you study. So for them, the maximum they know is what is the use of the drug. But ADRs of the drug, yes, no knowledge. So physicians don't want to work deep into that area. So only clinical pharmacy students can work on this and can prevent this ADRs or reduce at least the effect that is created by the ADR for the patients, so that immediate action can be taken by the physician to improve the patient safety. So I think by this now everyone would have been known about Pharmacovigilance Program of India, which we call it in short as PVPI, which is the body which takes out all the ADRs from the whole country. It is running from Ghaziabad, okay, our Pharmacovigilance Program of India. So in 1997, we joined WHO ADR reporting program in Sweden. Actually, that was Uppsala Monitoring Center, which is the pooled organization which collects ADR from the whole world, isn't it, Arnold? Though all Indian ADRs are getting reported to Pharmacovigilance Program of India. In 2004, NVP program was officially inaugurated by Central Health Minister, coordinated by the CDSCO. And officially, the term Pharmacovigilance Program of India was on 14th July 2010 with AIMS as the center in the New Delhi, and thereby whole India starts reporting to the PVPI center. So whatever adverse drug reactions you monitor at your place, that is not to just document at your place and keep it, lock it in a locker and keep. No, that is not at all the way the ADRs has to be. Even if it is a single ADR, that has to get reported immediately to the concerned organization, because that gives the alert. Oh, such a drug can cause such a reaction. So people will start observing about the drug. So if all over India, same reactions are getting reported about the drug, then they create the safety signal. And based on all this only, the effect will be shown in the market. So you can see certain drugs will be used over 5 years. After that, they'll tell the drug is withdrawn from the market. Certain time people will tell this is used for, like only few months, then the drug got withdrawn. So the drug gets withdrawn usually because of their potent adverse drug reactions, isn't it? So unless you report, the governing bodies will not be knowing that what is happening. So even your one reporting of ADR makes a big difference in taking the decision by this government or PVP or anybody, isn't it? Regulatory people to take a decision, your reporting matters a lot. So if you take this PVPI, they approve adverse monitoring centers, adverse drug reactions monitoring centers, which we call it as AMC. So before it was like, they have given only to the government sectors. But then, for example, if you take my department, pharmacy practice at St. Philomena's is approved PVPI reporting center. It is a AMC which is approved by the Ministry of Health, because we used to report very quality areas. We were reporting to our TB hospital in Bangalore. But then later they saw the way our reports have been reported. They were so impressed and they declared our department itself as a center. So we are a approved center by government. So any areas that we observe in the hospital or anybody, physicians outside or anybody can report that adverse drug reactions to us. We ensure that every month within the first week, we give all the ADR to this PVPI. We have certain forms. So in that forms, CDSCO form, we'll fill all our patient details, reactions, everything to them. And we used to submit to that PVPI, isn't it? So, and is it only for drugs? No. You can do it even for your vaccine. You can do even for your blood and blood transfusion products, because always we concentrate on drugs. We never concentrate on this other part. But again, I'm telling you, that was also the job of a clinical pharmacist. When you are into hospital, take that every single patient in your hospital has been taken care by you in all the aspects. So I always tell not to stop with the drugs. We have vaccinovigilance, isn't it? So many vaccines are getting. Do we think that vaccines are not causing adverse reactions? They do. So we monitor even the vaccines induced reactions. We monitor the blood. That is another big area which is not at all concentrated by anyone. Okay, as a clinical pharmacy students or people, if you are interested, you have done your B Pharm and you want to join your M Pharm, kindly keep it in your mind. Your opportunities are wider and wider to do it in a hospital. So you have your hemo also. So blood and blood products will cause a lot of adverse reactions. No one even would bother that. But we are tracking it from the year 2013. We were the first people in a pharmacy institute to start that time, 11-10 years back. Is it or not? So these are all the areas where we can concentrate. See, there is only one word: ensure patient safety. Provide complete patient care. This is what should be the motto for a clinical pharmacist when you enter into a hospital. So we are regularly reporting. This is one of the pamphlet we used to do the sensitization to our colleagues, our physicians, all the people. So report it, even if it is antibiotic-induced diarrhea, kindly report it. Don't think that this is not a big deal. No, there is no such a thing as are there. So kindly, you get involved into that. So pharmacists can play an important role at all levels in the sense like for reporting, for monitoring, for preventing, for all the way the pharmacist can do a great contribution. Sensitize the other healthcare professionals. This is very, very important. No one is not aware that, okay, I can report it. There are certain forms to report it. Somebody is hearing me when I say something is wrong, isn't it or not? That is not there for many of the healthcare professionals. So you tell your fellow nurses, tell your fellow physicians. So you don't do anything, just give a call, give out a call. Suspected adverse reactions are there. We will be reporting it out. So you promote, you sensitize them. What is the importance of monitoring the adverse drug reaction, reporting the adverse drug reactions? So all this has to be told, because no one bothers on that area, isn't it, Anna? So we have to sensitize them and promote the community pharmacists in reporting. I have added this because they are the one actually who gets more area, but they doesn't have the knowledge to report it off. So you stay at some place, you run a pharmacy, your friends run a pharmacy, sensitize them, tell them, because definitely if I have got a drug from one pharmacy, I would like to, if I get a reaction, I would like to go back and tell, hey, you dispensed me this drug. Next day morning onwards, I got rashes all over my body. So that person is the perfect person first to hear the adverse drug reaction. But it is just listen, it is just forgotten there itself. That should not happen. Sensitize your community pharmacist people. You provide them the form. The forms are available in the website, so you can just download it. What you have to say is ask them to fill nearby ADR center, whichever, like our department. If you are in Bangalore, you can report to us. See, I have shown the contact, everything. You can just report to us. What we need is just the data. If you are busy to not to do that, we are there only to do that. Okay, so report it wherever it is. You just can report. They have the app now. No one can breathe without even internet, right? So it has app. Directly in app you can upload your ADRs. There are all possible ways to communicate to the regulatory people. Kindly promote in doing that. Very, very important area, patient counseling, isn't it or not? So the logic of patient counseling is, when someone comes and tells to me, hey, you'll be all right, there's nothing for you, you'll be fine, just do me one thing, take this drug this time, inform me, I'm there. If you have anything, please do give me a call, I'm there. You're nothing. When somebody gives us this warm words or a comfort words, that heals a patient this way, isn't it? And when I understand what I have, my adherence will increase, my compliance will increase, isn't it or not? Better understanding of illness and role of medications in their treatment. Suppose I have my HB very low. I have been diagnosed as anemia. You take, women are more prone to anemia. In India, though, no woman will go to hospital for getting its treatment also. Because women feels we are extreme superpower. Everything can heal by themselves, isn't it or not? But something happens to someone in family, women will run. Wherein to us means, tomorrow we will go, day after we will go. That is the mentality for women, isn't it or not? So suppose if a woman has anemia, no, she will be in this mentality. Why should I go to hospital? So by chance she has come. Your patient counseling should be in such a way. Why this treatment of anemia is very, very important, isn't it, Anand? Like you take tablet, it will get over. No. Why anemia? If you don't treat your anemia, what are wrong? You just tell a patient, you'll get a heart attack. Will they take it easily? No, they'll not take it easily. Oh, what to do? That time also she'll think, what my husband will do, what my children will do. Husband fellow will marry one more thing, but what my children will do? Any woman will think on that, right? That is how a woman is. So in that way, you have to make them understand the illness. See, it is just nothing. It is just anemia, no problem. But completely you take your course 3 months. If they have given you iron tablets, please take the iron tablets. If you leave like that and if you do work continuously, this may cause you congestive cardiac failure after a few years. So when you tell that, you think she will skip the medication? She'll not skip the medication. So better understanding can happen only through patient counseling. And per day, 50 OPD comes. Which doctor can spend you 20 minutes with you personally? No, Nobody has the time to do that. 50 OPD, 100 OPDs are coming. Physicians are busy with that people. They can't spare some 20 minutes for one patient. But who can? Who can give the exact package of knowledge in a very better, rapid, creamy way is we people. Your clinical pharmacist, even community pharmacist, anybody in total a pharmacy you take. They have to counsel the patient. This is what always feels. No community pharmacist will tell, take it with this, don't take it with this. No, they won't counsel a patient. Same thing would have to be with a clinical pharmacist when it comes. You don't just be, okay, don't send a patient like that. Counsel your patient. Tell them what is their disease, what for this drugs has been prescribed. If I know what is my problem, my medication adherence will improve. I won't try to skip my drug. I will take it because I came to know that I may suffer with these complications if I don't take. See, now what we can see is, I always tells even to students or wherever I go is, now we have got a problem called as idiot syndrome, isn't it or not? After COVID, we are facing lot of problem with this idiot syndrome. Everybody can use Google Mata, whatever Google Mata is telling, we all are believing. So patients comes and tell, see, you have given this drug, but this is showing cancer is one of the side effects. Should I take? This all happens because of the less knowledge about it. Google does not give you 6 years what that MBBS person has done it, right? Or 6 years of PharmD, what you learned in your course, Google cannot teach them, isn't it, Anand? So when you make them understand the importance of drugs, definitely their compliance will increase. When the compliance increases, there will be more effective drug therapy, and drug interactions and ADAs can be prevented. So you can tell your patients, okay, for example, you have given the patient ATT, antitubercular therapy. So you have given an ATT, you can tell, so 15 days afterwards, you just come, do your liver function test, we'll see. Because we all knows all the ATT has the hepatotoxicity as the ADR. So what you can tell, sir, just 15 days afterwards, come do one test, blood test, and see, we'll just check it out. So what you can do, the moment you come to know the values are abnormal, you can modify the dose of the drug. Or you can, if you want to stop a drug, you can alter it of the drug. So drug-drug interactions, drug-food interactions, you can tell, please don't take with this drug. Please avoid these foods when you are taking it. So all those things can be counseled when you are going with a patient. Very simple is improved quality of life. That is what I told in the very first sentence itself. If a patient feels, I have somebody to take care, I can approach these people, then that positivity itself can change the life of a patient. So only that can be provided by a pharmacist. Only a clinical pharmacist can give that, because no others has the knowledge to do counseling. Physicians doesn't have the time to do counseling. So both is there with our profession. So we can improve the quality of life of any patient, isn't it? Information on self-care management, fine. Another area, I don't know how many clinical pharmacists or people, those who are pursued clinical pharmacists are working on it, but that is a very sound area where I can tell that we can show our maximum skills in this area. Identification of the poison, very, very important, because patient may not be in a conscious state when patient comes here, isn't it, Anna? So the patient will not write a letter and come, I drank this, like that. No one will come, right? So patient will be usually unconscious. So if I want to start a treatment, first we should know what poison would have been consumed, isn't it, Anna? So identification of whatever I'm listing with the poison management, this all can be done by the clinical pharmacist. Kindly that you can keep it in your mind. Identification of the poison. So why identification of the poison? In the sense, majority of the poison cases will be drug abuse, drug induced, isn't it or not? They take 20 alprazolam tablet, they take 40 amlodipine tablet, they take some benzodiazepines and come, isn't it? So maximum poisons would be the drugs. The quantity increases, a drug becomes a poison. So majority of them. So as a clinical pharmacist, you are the most perfect person to identify what that could be. Isn't it, Anand? Because you know what class the drug belongs to, you know what is the mechanism of the action of the drug, you know what are all the adverse drug reactions the drug can cause. See, imagine a person who knows all this is only a clinical pharmacist. So identification. You are the one who know the PK parameter of a drug. What is the half-life of the drug? So the drug was being consumed at this time. This many drugs was then. So what is the maximum tolerable dose of this drug? So how much this patient would have now intake this? So what should I do? So suppose, for example, 20 drugs has been consumed. You are the one who had to calculate what could be the half-life of this drug. What is the maximum tolerable dose of this drug? So it is only a clinical pharmacist because you have a good PK knowledge about your drugs. Antidote, very, very important. Majority of them are drug-induced. So you have to know about your antidotes. It can be even for poisons, because we get a lot of organophosphorus poisons even in our hospitals. It is only the family students who used to calculate pralidoxim doses, atropine doses, and give it to the physician. By the time they enter into the casualty, the history will be collected, and immediately the dose will be calculated by the families, and it will be handed over to the physician. So this is all what we normally do in our hospital premises. So definitely you can do this antidotes dosing treatment plan. So what we should do, should we go for symptomatic treatment? If it is, what are all the drugs that has to be taken? Okay, patient is completely on vomiting, patient is on diarrhea, or whatever it is. Based on the symptomatic treatment, symptoms, the treatment has to be started for the patients. Monitoring outcomes. So you have to monitor whether all the vital parameters are improved, or whether there is any liver or renal profile issues happens. So all this has to be monitored only by a clinical pharmacist. Awareness. So this I can even include in counseling, because when you prescribe certain people this benzodiazepines, you have to inform them how should they take, how long they can take, which dose is the maximum tolerable. So all these things, awareness can be created by the clinical pharmacist. Actually, we have made the separate manual for this. Okay. We have a poison management manual which is made by our department and submitted to the ICU of the hospital. So if you can't think, you can't Google and then you cannot take a treatment. That is all needs an immediate effect, immediate reaction should come from the hospital. So for make things easy, we have made the manual. See the poison, see the antidote, see the dose of the antidote. So within 5 minutes, it is easy for a physician to take a decision, because the manual is made easy from our department and kept in the intensive care unit. So this is how we ease our poison management in our hospital. Absolutely done by the clinical pharmacy students only. Okay. TDM, therapeutic drug monitor. I can say that there is no player who can compete with us in this area. Isn't it? And a solo player we tells, right? We're the solo player to do this TDM. Very rarely carried out by any clinical pharmacist. That also I have to tell, because it involves quite costlier instrument to monitor. Otherwise, I can tell there's no competitor for you in particularly this field. So management of a patient's drug regimen based on plasma, serum, or whole blood concentration of a drug. So I have to monitor, I have to ensure that the patient is receiving optimal drug therapy, not a higher dose, not a substandard dose. Okay. So because especially this is for narrow therapeutic index drugs. So everyone would know, so I'm not going in detail to that. Especially for all the narrow therapeutic index drugs, we carry out the TDM because the concentration of the drug is getting maintained properly. So designing patient-specific drug dosage regimens based on the PK and pharmacological character of the drug. So TDM can be designed by a clinical pharmacist in the hospital, provided if you have a HPLC or other instruments to monitor this, then this is the absolutely a very good field to work on, and it gives a great support to the physicians in fixing a dose for the patient. I can say that it is an individualization therapy. For each patient, what is the dose, rather than going for the common dose. A very broad area, but I could see very less of the people works on this area. I'm telling you, you can concentrate and there are no competitor for you in this area. So recommending or scheduling measurements of drug concentrations in biological fluid, you can tell which biological fluid will be more suitable to measure the concentration. So monitoring and adjusting dosage regimen, as I was telling that, so your dosage regimens can be adjusted by carrying out this TDM. So communicating patient-specific drug therapy to physicians, nurses, and other clinical. So once you measure the concentration of the drug, you can immediately convey to your physician so that the physician can take a decision of either increasing the dose of the drug or reducing the dose of the drug. This needs absolute PK knowledge. If you are good in your pharmacokinetics, then this is the area where any clinical pharmacist can excel in it. AMR, antimicrobial resistance, isn't it? I tells that another 5 years or 10 years, we all will die with AMR. Cardio, cancer, or other diseases are going to take second, third, fourth places, wherein this fellow will tell, I'm the number one. And he is going to be the number one. No doubt in that. And this is another area where you have lot of funds to work on. You have lot of opportunities to work on. AMR, antimicrobial resistance. And 50% of the credit of AMR in India has to be given to our community pharmacist. Isn't it, Anand? Their mistakes has led to this. We have to accept, because it is our profession. We can't just keep our eyes closed. Isn't it, Anand? We don't see any community pharmacist making a full course of antibiotics. So here you come, they'll cut and give one erythromycin. That is common in India. Ma'am, we got 4 rupees, 4 rupees, only one will come. He see erythromycin as a business. So no one is worrying, how are we, spoiling our profession. The profession which is meant to do patient care is the other hand doing the opposite to the community. So AMR is one field. If you have a good hospital setup, if you are getting trained in a good hospital, then please, if you have not taken initiative on AMR, kindly go and start this work. Start working on this AMR. So ensure appropriate microbial susceptibility test reported. Actually, I can tell you, pharmacists are the one who can make use of very rational use of antibiotics in the hospital setup, isn't it or not? Because we are the one who knows the history of a patient. So we has time to go through the files of a patient completely. So in that scenario, you are the person who can do a effective way to reduce the error, reduce the ADR, choice of a perfect drug. Because why I'm telling you, errors why we have written is, majority of the errors happens in the hospital only in the antibiotic area. Either the nurses don't administer in the chance that they don't administer properly. So because if you want to go for a parenteral antibiotic, the nurses won't dilute it properly, isn't it? Because almost all the antibiotics takes little time to get dissolved, isn't it or not? Either you have to dissolve with IV fluids, or either you have to dissolve with your distilled water. But what they will do, they'll do like this. They'll shake for a few minutes. It won't even get dissolved completely. They'll withdraw 5 ml or 2 ml. They will administer to the patient. Rest of the drug will be lying in the vial only. Isn't it, Anna? So the problem was not with the physician. The problem was not with the patient. Because of the error that has done by a nurse, you are making the patient to enter into a so-called resistance. Why? The patient may not show some improvement. One day doctor will see, 2 day doctor will see, oh God, this antibiotic is not fitting for this patient. Okay, let me go for a higher class of antibiotic. Then he will make the patient to go into a higher class of antibiotic. But what it would be, the patient would have responded to this only if full dose would have gone to the patient. So This is how, if you are there, this error can be prevented. If this error can be prevented, unnecessary exposure of antibiotic can be prevented. So this is a job of a clinical pharmacist. And same with adverse drug reactions. Why adverse drug reactions? Antibiotic dose may not be the same for you, me, or a third party. It depends upon my comorbidities. Am I diabetic? Am I CKD case? Am I other profile? So my comorbidities matters. Sometimes what will happen, they won't see the other comorbidity conditions. They just will write off the dose. But if you are there, what you will do? Sir, you have written piperazoline. You have written 4.8 gram of piperazoline. But did you notice cases of CKD and creatinine is already about 2? The moment you tell, your physician will catch, oh, how come I gave such a dose to a high creatinine person? They'll reduce the dose. So you avoid the ADR there. Isn't it or not? So that is how a clinical pharmacist should work. So I'm telling you, a lot of research can be done in this AMR. Lot of funds are available to do in this AMR. And we are very happy to tell that our hospital setup, we have reduced this AMR so much, because of the continuous work on this antibiotics area. So everybody can do on that. So you can avoid all the nosocomial infections. That is what it is. Your hospital occurred infections, isn't it, Anand? So that you can. So for that, what you need to know, where you are located, which is the most common organisms involved in causing infections in your area. So which are all the most common instruments that is causing infections? The sterility issues comes, right? Which are the one which causing in your hospital setup? Which organism is more sensitive in that? You can do a study, submit a report to your hospital. If you're pursuing your clinical pharmacy, you see the change what your hospital can go through. Isn't it, Anna? So this is another area where all the clinical pharmacists can work on it. This is the new term everybody would have heard, antibiotic stewardship. So every hospital, every NABH accredited hospitals are doing this program. It is nothing but it is an interdisciplinary team. That era is over. Doctors will write, others will follow. That era is over. Now we are in an era that you are a microbiologist, kindly give your input. You are a clinical pharmacist, kindly give your input. You are a nurse, what are your difficulties? Kindly give your input. I'm a physician, I'm putting my input. Come, let us work together. Let us work together. Let us choose a very proper drug. Let us ensure the patient's safety. This is the scenario we are in. We are in that generation. No more solo things people can decide here. So your antibiotic stewardship is same. It is a interdisciplinary. It contains surgeons, microbiologists, clinical pharmacists, and other physicians. We work together and we ensure that the antibiotics are used properly in your hospital setup. We have in our department this antibiotic stewardship. We have a team to work on it. And we have students who are exclusively working on antibiotic usage in our department. So this is how we are ensuring, at least, this is not a great thing we have done, but at least 1% contribution to prevent this AMR we are trying. If you have not started, please do start at your working places also. Drug-drug interaction, theoretically we study a lot. So since I was mentioning before, it's all a chemical. You can't expect that they don't interact with one another or they don't cause any unwanted effect. They are chemical. They are prone to do that. So this is another place regularly, proactively, you have to check your prescriptions for the drug-drug interaction. At times, doctors, it may slip from their mind what is the past history. So it is you, clinical pharmacist, who has to collect the history, who has to know about the medication history, and by chance any drugs, for example, an asthma patient, they have written a beta blocker. Immediately you can bring it to the notice, sir, but that looks contraindicated. Okay, then they will immediately change the class of the drug. So it is only the clinical pharmacists who can do. So majority of the hospitalizations, and like this is one area where lot of economic involvement is also there. When you get more and more drug interactions, then what it will be, you will be pushed to get hospitalized, or if you are already in hospital, it can get extended. Isn't it, Anand? So you will have your financial burden also when the proper drugs are not chosen for you. And this is the where you have a good interaction between your physicians also. See, if at all someone says, I say, but my physician don't listen, then I'm not ready to believe, because the way we convey, every physician will accept it. You just has to, it would have not been in their mind. The moment you go and say, sir, such and such drugs has been given, is it fine? We can change. Our communication is a big deal there. So when you say, definitely they will consider it and definitely they will change. So the another one area where you can work is drug-drug interaction. The another is drug-food interaction. Whether it is, both are friends or both are enemies, we cannot. But both characters are there for this, isn't it or not? Sometimes food acts as a beneficiary, sometimes food acts as a opposite way. So drug-food interaction, I'm telling you, 0% people will consider this when they prescribe. That is why I mentioned in patient counseling, being a clinical pharmacist, you have to emphasize. So when the patient is taking, what you should avoid, what you should take, everything you have to inform them. So drug and food, we take this area very lightly, but I'm telling you, this is a huge area where we can concentrate more. So if you're dispensing, if you're prescribing, or if you're counseling a patient, if the patient is on a particular drug, you can tell them. So for example, you want telmisartan to be given. You can immediately tell telmisartan, since has the adverse drug reaction of hyperkalemia. You can ask the patient, please reduce all the potassium containing foods. Don't drink 2 to 4 tender coconut daily, because tender coconut is full of potassium. So you can tell, reduce your banana, reduce your, tender coconut, because already your drug will cause your, potassium level more. Along with that, if you eat this, it will again potentiates your hyperkalemia. Even ginger and garlic, whatever it is, it all matters, isn't it? With anticoagulant, don't take this, garlic. So you have to advise the patients. So that you have to tell. So in that area where you can work, you can counsel your patients on it. You can work, because I can write and give. No one will concentrate on the drug food interaction except the CP. So people has to, first we should know, and then we have to counsel our patients regarding this area. Then query usually, when you are in a hospital setup, definitely you will get a lot of query. We have our drug information center, where we get queries from the hospital. The queries can be from the physicians, nurses can ask, the resident doctors can ask, or even the patient attenders can ask when you do your counseling also. So anybody, but you have to be available there to answer. That is more and more important. So it can be the source of information. So ensure the availability always in the hospital premises. This is what I always tell. If I commit, I will work on it. My presence matters. I'm not telling me, the profession. Our presence is very, very important, isn't it? Or not? When someone is in need, they wanted some surgery is going on. They wanted to calculate the dose of a muscle relaxant. They are calling, and you are in a cinema theater sitting. You're not responding. There's no point, right? So we have to ensure that you are available. Physically presence is the preferable, if not at least by call. They can call you and they can get it clarified, because time won't wait for anybody. The query would be emergency, isn't it or not? If they have time, they'll only go back, they can refer in the library and they can read. Since there is a lack of time, they call us. They need somebody who can answer very, very immediately and quality. That is more answer, and then not some answer. So it should be unbiased, isn't it or not? So you can't give a wrong answer. Actually, I saw it might be 200 mg, I think. No, that kind of answers can never come from a CP. Sir, 200 mg, sir. Yes, BD, you can go ahead, no problem. That confidence you should have. So unbiased you should be. Response should be immediate. Yeah. So I'll get you back, sir. I'm in theater. Another give me half an hour. Operation theater patient may not be alive until your theater is getting over. Isn't it or not? So response should be immediate. And whatever you answer, document and keep it, because it is easy for future references, isn't it? So document it. Casualty emergency. As of my knowledge, I am not seen CPs in this area, but I ensure that my students are posted there because that's one area where you can learn a lot. You can provide information to, and you can learn to. So approximately 3.6% of patients prescribed with inappropriate medication. Absolutely. The thing is, like, hardly one physician or someone will be there. So they just write it off. And 5.4% patients will have potential for an ADR because you don't have anybody to work on it. The moment the patient get received, you act immediately, you prescribe, and then you are sending. No one is cross-verified there normally. So 38% of patients presenting to a variety of EDs worried that error might affect them. Error might definitely affect them. That is the thing. Medications are often dispensed directly without any pharmacy review. And it is a place of urgent and high stress. This is what I wanted to tell. That is why we call it as emergency. You don't see a patient walking, enjoying, talking, and coming and entering an emergency. Your patient is in a stress situation. So you have to act immediate to the patient. So you don't have time to Google and see what drug. You don't have time to see that, recall it. Second year PharmD I studied, but I am in 5th year PharmD. I'm not. No, you don't have options at all to work on that area. And like, since that has to be acted immediately, by the time the patient comes, it should be the clinical pharmacist who should take the history. Tell me, sir, are you diabetic? Are you a hypertensive? Or fast, you have to collect the medical history, medication history, pass the message to your physician so that you can avoid all the irrational choices of a drug. Sir, the patient is a known asthmatic case. Okay, immediately it will flash to his mind. What are all the drugs I should not prescribe? Sir, patient is already on a double OHA. Oh, is it so? The patient has come with hypoglycemia. Okay, fine. Measure this GRBS. Isn't it or not? So you don't have time to think, sit, and then take a decision later on. It is a stress situation. Other than patient, attenders will be in high stress. You should know to professionally deal all those people. You can't blame. Someone has committed suicide, for example. They're coming to an emergency. What kind of situation you will expect there? The patient may not be in a responsive situation, but then attenders will be in the most stress situation. But it is you, clinical pharmacist, who has to calmly take the situation into your hand and collect all the data and pass it to the physician so that the physician can take a decision. Emergency is one area where you can become the best clinical pharmacist. I can tell you, isn't it? So these are all the various activities we have seen. We have some more activities, I know, but I have taken a lot of time. I'll try my level best to cut short it. So what as clinical pharmacist I should need skills? I have written certain skills. I don't know. I'm varied from others, but sound knowledge. Don't confuse your marks and your knowledge. I always tell to my students the same thing. I don't want gold medal. I don't want university rank. No, there's no point if you have a university rank and you don't know about a drug. There's no point. Passing 3-year theory exam doesn't mean you're brilliant. I'm very clear on it, and I ensure to my students, take knowledge, develop skill. Don't want that just mark. So I don't know about other courses. To be a clinical pharmacist, what you need is knowledge. Should be thorough with your pharmacotherapeutics. You should know about your drug, its dose, its ADR, what is mean by dosage adjustment, how should I do? You have to be thorough with it. So your sound knowledge is very, very important. Multitasking, isn't it? Have you seen women? They will be making one side their kid ready. They will be doing kitchen work. Isn't it? That multitasking nature should be there for clinical pharmacists. Very, very important, because you will have multiple work to carry out at the same time. You have to be a multitasking. You should know to do counseling. You should know to do and talk about an error. You should know to find the ADR. So you should be a multitasking person. Good communication skill, very, very important. Not only for this, for anything, isn't it, Anand? Communication skills are very, very important. Here I mean is both verbal also, and I mean non-verbal also. Very, very important is your non-verbal communication skill. Isn't it, Anand? You can't be, when you do patient counseling, you can't be doing like this and do a patient counseling. Isn't it, Anand? Patient should feel that person is listening me. He is sharing my pain with him. That feel should come to the patient, isn't it, Anand? And you're going to do your communication with either patients or physicians, so you have to have a good communication skill. You should know how to talk to a physician. You should know how to talk to a patient, isn't it, Anand? Totally, I expect this. We should have a humbleness at all the time, isn't it, Anand? The humbleness is very, very important. The way we dress, that attire should speak about you. They should feel, yes, he's a physician or he's a pharmacist, isn't it, Anand? Torn jeans, colored hair. We are not running a party here. People are in pain. You're going to meet people with pain. There you can't go with color nail polish, this. No. By looking at you, yes, I can share. He will take care of me, or she will take care of me. That comfort the patient should feel the moment they look at you, isn't it, Anna? So non-verbal is also very, very important, the way your verbal is. Okay, develop your communication skills. That is very, very important. Highly committed. This is much more needed for our profession than compared to any other profession. I would like to share this here all the time. If you see a college setup, people always used to feel jealous on pharmacy practice teachers, because they feel, because all other usually will be in the college, right? We all will be in the hospital. So there is a feeling for all over India, I'm telling, to all the people of other departments, then they are in hospital, they are enjoying, isn't it? It is not so. We are very, very committed, because patient won't wait for you, time won't wait for you, above all, death won't wait for you, isn't it, Anand? We are not playing in lab, we are not dealing with animals, we are not doing computerized experiments. All our association is with patients. A life is a life which never you cannot replace to anybody. So you have to be highly committed. A query comes, okay, half an hour afterwards, I will report. If you have that mentality, you're not fit to be a clinical pharmacist. Okay. Our department opens 6:45 to 7 early in the morning and runs up to 7:30 to 8 in the night. So every single student is committed here. Okay, there is no students comes and complains. You know Bangalore climate, right? You want to sleep in the mornings up to 8, but nobody comes and complains. You have asked me to come at 7 o'clock to take care of this patient. No, that is committed. So the first skill you want to develop for you is commitment. I have been committed, isn't it, Anand? So that commitment is necessary if you want to be a successful clinical pharmacist. And patient care, as all this is are needed to provide a better patient care. Always what it should run in your mind is, every single patient is mine, and I have to take care of my patient. See, there is a big difference, you and physician. The thing is, if you are working as a clinical pharmacist, you will be paid a salary. But you are in your internship, whatever you're going to do, your profession is what you're getting trained whole 1 year in your internship. We train you like anything in that 1 year internship for what? To be a best professional when you go out. So if at all any one of you among these people are in your 6th year or going to enter into your 6th year, kindly take that 1 year as your golden period of learning. Kindly learn. Don't do the course for your teachers. Don't do it for passing your course. Take it that 1 year as a golden period for you to learn. That 1 year, if you can't learn, you will not learn anywhere else. Isn't it, Anna? So that is, so the aim is patient care. So that 1 year, learn all this, whatever I have said so far, and be a good clinical pharmacist at the end of 1 year. Isn't it? So you are not being paid, but your physicians are being paid. But yet, without getting some salary, I do a good for patient care. There is no better satisfaction than this in the world. So take it like that and do your profession and do for the patient care. So coming to the opportunities, because as I was mentioning the before myth itself, people has a feeling that after PharmD, no job, after M.Pharm pharmacy practice, no job. Please, if someone tells, throw them, you be away from them. It is a negativity. You have lot of opportunities to work. The thing is how you take up the opportunity. See, I have just put 3. Many are there, isn't it, Anna? So you can have your hospital, that is clinical pharmacist. Okay, you can be working as a clinical pharmacist. Nowadays, all the hospitals are trying to be for NABH accredited. When the hospital has to get NABH accreditation, there is a compulsory that they should have a clinical pharmacy department. So definitely there are a lot of openings in the clinical pharmacy sector. So you can work there. Then I have put the center as books. It can be you can go for teaching or you can pursue your higher studies also. See, it is an integrated PG course. You don't want separate PG after your PharmD. You can directly go to your MS or your PhD. So you have for your higher studies a very open platform there to go for it. As a clinical pharmacist, I'm telling you, at least in the bigger cities of India, we have lot of openings. From past 1 month, 4 to 5 hospitals are asking me clinical pharmacist. Actually, I don't have my students to send there because others are all placed. Isn't it, Anand? So that is the scenario. If someone says there is no vacancy, there is no opportunity, kindly don't believe. Where the difference is it, how are you skilled to take up the job? If you have got your degree, then I'm sorry, no job for you. If you have learned your degree, yes, you have multiple opportunity in front of you. Isn't it, Anand? Every hospital started recognizing clinical pharmacy. Every physician would love to work with clinical pharmacist. Scenarios are completely changed. So you have lot of opportunity. And pharma industry. Earlier, industry was not taking PharmD. Now, I don't see other than PharmD anybody in an industry. You go to CDM domain, you go to medical affairs domain, you go to PV domain. PV though is packed with only PharmD, I can see. Isn't it, Anand? So you have lot of opportunity. You have regulatory affairs. You have multiple domain in pharma industry where PharmDs are getting enormous job there. Isn't it, Anand? And it is now compulsory from the regulatory agency of India that PV team should be there in the company. So your opportunities are more when if at all you learn your basics very good in your course curriculum, it is easy for you to enter into your industry. You don't want anything else. You just need skill and then you need the knowledge. You can enter. Regarding government sector, very, very long back, Karnataka was telling they are ready to take up in the government sector. We are keep on asking them also, take them as PHCs. When nurse can sit, why not clinical pharmacists can sit? Imagine. So we are keep on requesting to our council bodies that let PHC be taken up by the clinical pharmacist, so that lot of government openings will come for the clinical pharmacist. Though we have those opportunity, always I ensure that also you have to be knowledge and skilled to enter for a job. See, I am asking you, sir, give me one job. Okay, I will take. After 4 days, they're telling, what, madam, you have sent this person who doesn't know what is meant by amlodipine. You imagine. Why I'm speaking things practically. I don't want to decorate ornamental words. I don't want. Though it is a platform of sharing information, I don't want ornamental. To be frank, practically, how many PharmD students are really getting trained completely at the end of the course? That becomes a big question. So if we want to ask government, give them some government job, have we really caliber to do that? Do I have that knowledge to do that? That question comes to our mind. So take that as an opportunity to learn completely. See, if you people show your talent only, people like us in academics can go forward and ask government, sir, you can do with a BSc nursing. Our PharmDs can take up completely a hospital and run. That confidence, if we have only, we can go and argue with some government bodies. Here the question, I'm speaking practically. It is not so. If I say go to words, people will look as if I am a Hitler. I have used a bad word because go to what? Go get me some adverse reaction. This lady doesn't have any job or what? Loser is you. Loser is your future generation. See, we all are settled. Isn't it correct, Manoj? We all are settled. We have done our courses. We are old generation people. With this academics, we will move off. But we are all struggling this much for you people and your future generation people. So if you want to question Pharmacy Council, if you want to ask someone, give us government job, next question coming to our mind is, are our kids are fit there? Could they manage that? That is the question. So that scenario should change now. You should change. You should take your curriculum as serious. And you should get it right. By chance, you don't have a facility, create the facility and study. Create the facility. This is a small world. Everybody can learn from everywhere. Create the facility and study, but don't take it as a course. See, I can tell us clinical pharmacy is not a job. It is an emotion. It is an emotion. Don't take it as a course. It's an emotion for us. Isn't it, Anand? So take it in that way. Then only job opportunities will come in government sector. Private, you have. Private, absolutely. You have as a clinical pharmacist openings. Industries are very happy to recruit PharmD students. You have, teaching, you have good opportunities. All those things are there. In government, if we want to prove ourselves, we have to first take the step of, yes, we are fit. That should be shown to the government. Then opportunities will fall on us from government sector also. Isn't it, Anna? So many opportunities are there. Always parents will ask me one question when they come for PharmD admission, salary, how much it will come? Isn't it, Anna? Anybody. All these things we work as, after all, for money, right? End of the day, money is what matters. So everybody will ask, ma'am, how much my son or daughter will get salary? See, package, we cannot tell. But I'll tell you, you'll get a very good package. And 100 people are coming out. If you want to be this one, you have to outstand there. If you have to outstand that, your knowledge and skill should be, like high than anybody else. So build up that. Once you get that, salary will fall on you. Isn't it, Anand? Companies only will hire you. Hospitals only will hire you. They only will give. So I could see my own students as clinical pharmacists. They will work in one hospital, another 2 months, another hospital will come. They will give you 20,000 extra, 10,000 extra, you come. They move. There, what you are doing is, you are establishing your footprints there. If I take this person, he will do or she will do. They will, that is necessary. Then automatically salaries will come. Isn't it, Anna? So don't bother about opportunities. Don't bother about salaries. Bother how should I come out with good knowledge and skill. That if you take care, rest things will fall automatically. Isn't it, Anna? So that is what. So these are all few glimpses of photos. We do many activities every month to community also. These are just a few glimpses I have taken in last just 3 months activities of our college it is. Okay. So with that, I'm winding off my talk. Thank you one and all for the patience learning of this to us. Thank you. Thank you so much. Thanks, Manoj, for the opportunity to me. Okay.
Thank you so much, ma'am. It was such a pleasure and such an interesting session. I learned personally so much of information about clinical pharmacy. So thank you so much for that. And participants, how do you felt about the presentation? Type in chat box with just one word of appreciation for madam. Ma'am, you can stop the sharing.
Yes, sir. Yes.
Have the Q&A session. Yes, so chats have started, and participants, if you want to ask question, please put in the chat box and I'll take up the question, or you can raise your virtual hand on Zoom and then I'll take the question for you. Okay, so Kura says, very much inspired with your presentation, madam. It's amazing presentation. Arif says, thank you so much, madam. Outstanding. It was informative, very informative, motivating, amazing, superb. Thank you so much, ma'am, for enlightening, lots of information. So these are a lot of words of appreciation for you, ma'am. And
thank you
truly
so
inspiring, ma'am, truly inspiring. And personally, I was not aware that so much thing happens in clinical pharmacy. I'm connected more with community pharmacy and retailers, so I was not aware that so much of things happen in community clinical pharmacy. But amazing, ma'am, really amazing. Truly appreciate your presentation and the way you told the presentation to us, ma'am. Thank you so much. So participants, ma'am, we'll take some questions.
Yeah, sir. Why
Okay,
not? No
perfect.
problem.
Participants, please raise your virtual hand on Zoom, and then we'll unmute you, and then you can ask the question directly with ma'am. That is how we do. And if you want to switch on your video, nothing like it. We'd really love to interact with live. Yes, Avijna. Avijna, please unmute. If you want, you can always switch on the video as well, and you can interact.
Okay, thank you for the opportunity. So my question is, ma'am, you had talked about drug-food interaction.
Yes,
So I'm in third family right now, but my question is, how do we approach this study? How do we relate food and drug, and how do we learn more about drug-food interaction?
See, since you're in your third PharmD, from fourth PharmD onwards, you would be visiting to your hospital, isn't it, Anand? And as of now, you have the subject of pharmacotherapeutics too. So you would be collecting some cases from your hospital for your practicals, right?
Avijna, you can unmute and interact.
No, fine.
Yes,
Whatever.
Yes, ma'am.
So you will be collecting some cases for your hospital for your PT2, right? You'll have some cases. So since you are in third PharmD, you can start learning your drug-food interactions theoretically. For example, discharge medications will be there in your cases, isn't it, Anand? Collect those discharge medications in your cases, and then you have lot of textbooks on drug and food interactions, isn't it, Anand? You can start theoretically. For example, as I was giving you an example of telmisartan, if at all your case sheet has a telmisartan, you can see which are all the foods this telmisartan is getting interacted, or any other drug, amlodipine, or any, it could be any drug. So even it can be OHS, whatever it is. First, being in third PharmD, start learning things theoretically now. Fourth PharmD onwards, you will start entering into your hospital. The moment then you can see the cases lively from your patient case sheets, then you can start working on it. See, learning in a sense, it is not immediate day one to learn. You can slowly, theoretically, you can start learning your drug food interactions. From fourth and fifth, directly from the case sheets, you can start learning and you can start working. Suppose if you wherever you study, you have a provision of conveying that to your physicians, or you will have some preceptor in your hospital from your department, you can convey to them, and that can get conveyed to the physician. Or by chance you got the opportunity to do counseling, tell your patient directly, please avoid all these foods when you take, or reduce the quantity of these foods. Like that, you yourself can counsel your patients. May not be, this is not the time in third PharmD to do that. Probably when you come to your fifth PharmD and sixth PharmD, you can definitely do that. Until that, start learning the theoretical drug and food interactions.
Yes, ma'am. Thank you so much.
Okay. Thank you.
Thank you, Avijna, for asking, and thank you, ma'am, for answering that question. And now we have a lot of questions in the chat box. I'll take one of them. Monica says, ma'am, I'm in the first year PharmD student. Everyone said that we can pursue MD after PharmD, but some say it is not possible. Could you please clarify?
No, it is not possible. There's no MD after PharmD. You can do your PhD after your PharmD.
Absolutely.
There's no MD. You can do your MS in clinical based subjects. You can do it. MS is there, but that you can do it in your clinical based subjects, like clinical pharmacy. You have pharmacology, you have clinical pharmacology. Like that, you have a lot of courses that you can take it up after your PharmD.
Absolutely, ma'am. Thank you. And I'm sure this question will be there in the minds of many PharmDs.
Yeah.
And a lot of queries, they keep asking on LinkedIn as well to me. So thank you for clarifying that, ma'am. There is another question from Pramod. He says, ma'am, I'm a Pramod PharmD intern. It was a great opportunity to attend your session. It was very informative. Thank you so much. So
thank you, Pramod. All the best, and crucial time for you to learn. Please keep learning.
Absolutely, ma'am. So there is another question from Asma. Ma'am, can you suggest for MPharm pharmacy practice, at which area for a clinical pharmacy which must be well knowledgeable compared to PharmDs?
See, that's a correct question, because wherever colleges that has PharmD and pharmacy practice, this pharmacy practice will be treated as stepmother child, and PharmD will be treated as biological child. Isn't it, Anand? Yeah. So because the reason is everybody concentrate on PharmD, but no one concentrate on pharmacy practice. So whomever has asked this question, wherever you pursue, whatever I said for PharmD, you have to you also have to take up the same activities, whatever I said for this one. Train yourself. And even in the pharma industry, you have lot of vacancies in, I can say you, in clinical affairs, that means medical affairs area, regulatory affairs area, and pharmacovigilance. Though majority of the companies are taking PharmDs into PV, but clinical affairs as well as regulatory affairs, even today, MPharm pharmacy practice is preferred when you want to go to industry. That protocol making, all those things are involved with only MPharm pharmacy practice people. But again, I'm telling you, there is no difference of PharmD and MPharm pharmacy practice. Try to learn all these clinical pharmacy activities wherever you are performing, wherever you're pursuing your course.
Perfect, ma'am. Well explained. Any other questions, participant? Please raise your virtual hand. Otherwise, I'll be taking questions from the chat box. So the next question is from Rajat. He says, ma'am, why is MPharm pharmacy practice person do not get doctorate, whereas PharmD graduate gets a doctorate?
Probably Pharmacy Council should take up this question. What is his name? Rajat.
Rajat, ma'am.
But to be frank, I'm opposite to the prefix of DR even for PharmD.
Absolutely, ma'am. I too agree with you.
I don't want. See, I'm telling you, as I was showing, Kathakali is different, Bharatanatyam is different, all are different. Doctor is a doctor, isn't it, Anand?
Absolutely.
A PharmD can't be a doctor. A PharmD has to be called as a PharmD. A clinical pharmacist has to be recognized as doctor. Prefers DR. I personally, being a PharmD teacher, for me, like a clinical pharmacy is like my breath. Even then, I don't support that. The reason is, I'm telling you, why should we compare with some other person and we should act and make up according to them? You create your own identity. Why it should be DR? Give some PR or CPR you give. Correct, right? I'm against Rajat. That's not, DR is not making a big difference. Physiotherapists are DR. A PhD in history is DR. A PhD in geography is DR. So prefix doesn't have anything to do with, okay. And there is nothing to feel for it, isn't it, Anand? So MPharm pharmacy practice can be MPharm pharmacy practice. It's a banyan tree, as I mentioned before. All comes under us only, isn't it? So I don't think nothing to feel on it.
Absolutely, ma'am. Well explained. Thank you so much, ma'am. Next question, Mr. Shrikant. You may please unmute and ask the question. If you want, you can also switch on the video.
Firstly, good afternoon, sir and ma'am. Thank you so much for such a wonderful session.
Thank you.
I am a second-year PharmD student, and my question is, what advantage does a PharmD graduate has over B or MPharm in working as a clinical pharmacist?
One thing is, you have got 6 years, they have got 2 years. Isn't it, Anand? The exposure you get is almost more than 100% than what a MPharm person gets, isn't it? And I'm telling you, practically when I'm speaking, your MPharm students may be 4 students, 5 students. You will be 30 students. The concentration for any teacher towards you is more than MPharm pharmacy practice, because I'm telling we are victims of that. Okay, so that is one. And another thing is your duration is more. MPharm in their curriculum doesn't have any specific curriculum, means you have 6 months of general medicine to be carried out mandatory as internship. You have minimum 3 specialties you have to take up in your 6th year, which is mandatory. That is not there for MPharm pharmacy practice. So if you take a cardio specialty, if you take a surgery, if you take a pediatrics, you will become a master in the 2 months. That MPharm pharmacy practice don't get, because their curriculum doesn't say them to go to a specialty. So usually what specialty exposure is not there for MPharm, wherein specialty exposure is there for PharmD.
Absolutely.
That is a big difference.
Absolutely. Totally agree with you, ma'am. Thank you. Thank you so much, ma'am, for clarifying that. Shrikant, thank you so much for asking that question. And we hope we clarified that question of yours. Another question is from YouTube. It is coming in from YouTube, ma'am. Rahul. He says, ma'am, can we get into clinical pharmacy after B.Pharm?
D.Pharm, no.
B.Pharm. Bachelor.
Yeah, bachelor, you have 2 options. You have MPharm pharmacy practice to be taken. You have post-baccalaureate, which is there for 3 years. You can take it up. So either one, whichever you're interested. MPharm pharmacy practice is 2 years. PharmD post-baccalaureate is 3 years. You can opt anyone if you want to come into the clinical practice. Both options are there for you.
Okay, ma'am. Perfect.
Most options are there.
Perfect, ma'am. So, so the same, he has another question as well. He says, what will be the minimum package for a fresher? And what is the highest package for an experienced?
See, experienced is absolutely individual based. Okay. Because how you perform, your salary rise would have happened, isn't it, Anand? So I don't want to comment on the maximum package, because it depends upon where you are posted. I mean, suppose for you take me as an academician, I have a 16 years of teaching experience. A same person of 16 years in industry, package would be triple, double, 4, 5 anytime. Academics is comparatively lesser than compared to an industry. Absolutely. So that I can't comment. Freshers, as of I have seen, as people are starting what 30K per month is what I have seen starting. But even I have students who has got 40-45K as their starting salary for hospitals. So probably your interview, the way you give matters. But roughly 25 to 30 is the starting presently going on in Bangalore and around areas, Hyderabad, Bangalore, Chennai, this is all going on. If the student is extremely good, they're ready to give 40 to 45 as a clinical pharmacist, I'm telling. Industry norms, minimum at least 4 lakhs they're starting up with. So that could be. Maximum package, probably I can't. Can't answer that.
Yeah, that is up to individual. Perfectly.
Yes. The way you work matters.
Thank you so much, ma'am. Next question is from Mr. Chandramouli. He says, what are the IT skills needed for clinical pharmacists? This is from YouTube, ma'am. I'm just reading the questions from there.
IT is very, see, right now, artificial intelligence is ruling. And IT knowledge is very, very important, because, see, how much ever I do, I don't document, it is equal to not doing. So, to document your ideas, to document your errors, to document or to send it to the concerned persons, you need your IT skills, very, very important. Because see, you can make a Google form easily, circulate, you can do a research study, span of 2 days. That gives a great impact. But that study can be done in a simple Google form, isn't it, Anand? See, that is very, very important. IT knowledge is very, very important. We don't want a computer science person knowledge, but your basic knowledge is very, very important. See, either for documentation purpose, or see, every PharmD student or a pharmacy practice has to do a research project. To do that research project, to make a protocol, to make your thesis, forget about everything, to do a publication. You should know how to write a manuscript, isn't it, Anand? So that knowledge, along with your, system knowledge, it is very, very, computer knowledge is very, very important. Very important. That's a good question. Very important.
Yes, ma'am. And we are in the digital era and everything is going digital these days.
Yes, sir. Digital. See, to make this PPT, also we need some basic knowledge, isn't it, Anand? So only with clinical knowledge, when I'm not able to portray that knowledge, there's no point with that.
Yes.
So definitely IT knowledge is needed. And I could see present generation, they are very good in that. We don't have a problem. See, for me, my department students helps me for documentation, but they're very good in it. I'm old. They are young. Their minds are young. Their skills are more in those areas. So that is very, very important. And see, you go to any hospital, all the hospitals are computerized. No physician is sitting and typing prescription. I'm telling my hospital itself. They'll dictate, they'll tell, students will write the drug dose, and then they will do that. They are the one who types the medication history, everything. So you need that smartness.
Perfect, ma'am. Yes, absolutely, it is needed. And
yes.
This is for any pharmacist students or faculty members who are attending. If you need any support in learning digital, then just contact me and I'll be trying to support you whatever ways I can. Another question is from Sohail. He says, ma'am, as a PharmD first year student, can we report ADRs?
Better to not do, because your clinical knowledge is very, very less here. Because identifying ADR is not easy. Isn't it, Anand? As I was mentioning earlier, nobody will be writing in the prescription, this drug has caused this ADR. So it is you who has to find out the ADR with the patient as well as. So first year you are studying your HAP. Still you have not studied your curriculum. So it is very tough to differentiate a drug-induced reaction and a disease presentation. Sometimes disease clinical presentation itself will be looking like an ADR. So you need a sound knowledge in it. Knowing or learning is not a bad thing, but don't do it because 100% that can't be a authenticated one. But you can start learning. You can learn how it is, or like what are the common areas of drugs, or what are the clinical presentation of a disease. Those things you can learn. But monitoring, that won't be. You have 5 more years, and you can definitely start doing from your second, third year slowly once you start your pharmacotherapeutics. Right now, it's a basic. So sit with the basic and go ahead slowly.
Yeah, absolutely.
It's always good to jump from first floor to ground floor, then 5th floor to first floor. Hurt will be very intense, right? So definitely you can do, but not at this point of time.
Yeah. Right now, learning should be the focus and implementation can be at the later stage. Yes. Absolutely, ma'am. Thank you so much. And Sohail, thank you for asking that question, man, because I'm sure many first years would have that question in mind. And there is another question from Rajat, ma'am. He says, ma'am, what would be your suggestion for B.Pharm students to get into clinical pharmacy practice? Would you suggest to get into M.Pharm clinical pharmacy or M.Pharm pharmacy practice or PharmD?
See, B.Pharm, if you are pursuing, as per our PCI syllabus, we have 2 papers right now, which is there in 7th semester on pharmacy practice, where they are teaching on all the basics of that. And you have your 8th semester, you have papers on social pharmacy. That is again a general talk only, nothing more on clinical. And you have a paper called as pharmacovigilance. But I think according to Rajiv Gandhi, it is optional only. I don't know about other universities pattern. But if it is PCI, then it should be the same for all over India. So we have it with 8th semester pharmacovigilance. See, there in B.Pharm curriculum, in both subjects, you can learn only theory. Getting a B.Pharm to a hospital, providing a clinical thing is not there in the curriculum. So that can't be happen. So PV, since anybody who is elective taking PV can study PV, you'll get a good knowledge about PV. Beautiful syllabus it is, because I handle for my 8th semester B.Pharm. Absolutely very good syllabus. 7th semester pharmacy practice gives you a basic idea about what is happening in the clinical pharmacy department. Practical exposure, no, for a B.Pharm. And if you want a clinical exposure to be done, you have to either enter into M.Pharm pharmacy practice or into the PharmD PB. Then definitely curriculum is in such a way that if you don't want also, we'll tie you in the hospital only.
Ma'am, but for a B.Pharm student to get into pharmacy practice, is it advisable to do a PharmD or M.Pharm is okay?
Sir, it is again individual, sir. Why am I telling us? I can't say M.Pharm pharmacy practice is good. I have clearly told the difference in pharmacy practice and this one.
Yes.
See, pharmacy practice as per curriculum, there is no specialty training. But within the 2 years, whatever we could train them, we are trying our level best. I can talk about only my institute. So we're trying our level best to train them in all the fields. Okay, but curriculum, if you put it in curriculum, colleges will make you compulsory. So PharmD PB, it is compulsory that specialties you have to go, they will. But M.Pharm pharmacy practice, it is the college. College can always allow a student to learn whatever they wanted to learn. So here in my M.Pharm pharmacy practice, if they want to go, if they learn, I never have stopped them, though it is not there in curriculum. But learning can't be stopped for any person. And we make projects in the specialty which the student is interested of. Normally we do like that. But suppose a student comes and tell, ma'am, I like only cardiology. We make project into cardiology so that another 9 months they work on the project. Exclusively they will be learning about that specialty. Excellent. Because sometimes people has the feeling neuro is my field, nephro is my field, cardio is my... If that is the case, we put the project in such a way that they get exposed to that area. That is how normally we do. Here I can give one answer that take a PB or a M.Pharm. If you take M.Pharm, ensure wherever you are taking M.Pharm, you learn completely. You take up your preceptors, be in complete touch with your preceptors, get it learned. Because curriculum doesn't say us to do that. But out of interest, definitely any teacher would help you to do that. You can approach. But curriculum, if it is there, a teacher is forced to do that. So it is their choice to take it up.
Okay, ma'am, there is one connected question from Ashma. So I think this very much clarifies. She says, ma'am, when MPharm pharmacy practice goes for a job as a clinical pharmacist, many hospitals actually prefer PharmDs, and they say they have better exposure in all the departments during internships.
True.
So what does a MPharm pharmacy practice can do for that? And if he or she wants to take that?
This is not only her. This is a universal question we face, because in fact, even many hospitals which approach PharmD is there, ma'am, like that only they will tell, because they feel is say 6 years of course, they feel their exposure is very good, sir. But it is not so. 6 years we have people who don't even do anything and pass and go. 2 years I have students who have extremely getting trained. So it is individuals. Even I used to say to whichever hospital approached me, you take a MPharm pharmacy practice, because MPharm pharmacy practice curriculum is equal to the curriculum of PharmD. Because their exposure is only for 2 years, all people are hesitating. It is their myth, but it is not so. So whomever have questioned you, gave this question, you develop your knowledge and skill. Nobody can say no to you. Isn't it, Anand? That is the answer for anybody who neglects it. Because I'm telling you, PharmD right now, or 2008 onwards, we are working. Before that, there was no such a course. MPharm pharmacy practice was the one which was taken up for them, isn't it, Anand? Because the curriculum is 6 years, people feels their training is good, but it is not. 6 years without training, got certificate students are there. 2 years who get trained completely, there are also people are there. So you develop your knowledge and skill and give the answer back, because that is a right question. Everybody has the feeling. Wherever you go to hospitals, we'll take a PharmD, they will tell. But there's no point, sir. That's a myth breaker. I have posted one of my MPharm student as a clinical pharmacist in a very reputed hospital here. But I didn't permit them. I told I won't give PharmD. I will give only MPharm, because they told me we wanted a person that is trained under your department only. I told PharmD or MPharm, they are trained under me only. Take it. And she is a successful clinical pharmacist.
Excellent.
So you only can show that to these people who shows negativity on the course.
Absolutely, it is totally on to us. So
yes, and you can. 2 years is a big time to learn. When we have a thirst of learning, even 24 hours we will learn. That thirst of learning is needed. That's all it is.
Absolutely, ma'am. Thank you. Thank you so much, Asma, for asking that question. I'm sure
Yes.
we could answer that. Ma'am answered it so nicely, and many of your MPharm pharmacy practice students, if you're having the same kind of question, then ma'am's answer would be the like a golden answer for all of you, and you should always try to focus to be the best one amongst the crowd. So thank you so much. And last question for the day would be from Shrikant. Can a second-year PharmD student work as an intern under a clinical pharmacist?
No, dear. Learn your basics. Be thorough with your pharmacotherapeutics. Learn your pathophysiology. And then, because working as intern is not to put a chair next to your physician and then look at this. No.
Absolutely.
You have to be in a position to answer. Hey, I'm not getting, tell me, amox is not sensitive to the patient. Give me one another alternate antibiotic to amoxicillin. Sir, amoxicillin is in syllabus, sir, but I have it is in third form, sir. You can't say. So as I was telling before, let us jump from first floor. Let us climb from ground floor to first floor, not to fifth floor at direct. But I'm very nice to see the eagerness of people to learn. I'm happy for that, because PharmDs should have that interest. But just wait for some period, at least up to third PharmD, learn things, and then definitely you can start. Because intern is not to just watch and learn. It is also to give inputs to your physicians. That is what internship is. So when you don't know the basics and the drugs properly, that is not a good decision to take up the job. Isn't it, Anand? So wait, and we can do it after 2-3 years.
Absolutely, ma'am. Thank you so much, ma'am. And I'm sure depending on the responses that I'm seeing right now, I would be love to invite you one more time.
Definitely, and, always there, sir.
Specifically, one session we need on patient education, ma'am, because that is something, patient counseling and education is something which many of our pharmacy students are lacking.
Definitely,
And
sir.
we definitely would plan one session on that. So, good participation from many students, and some of the faculty members also attended. Still, at the end of the session also, we have close to 55 people attending on YouTube and, Zoom. And the recording of this entire session would be sent to everyone who has registered for the session. And this I do as a ritual since 1.5 years I'm doing it. So this will continue.
That's a big kudos to you, sir. No, I have to. Such a wonderful job you are doing.
Thank you so much, ma'am. Thank you. And this is, especially thankful to all the participants who make, way for every Saturday as a learning day. 2 o'clock they come here and learn, and some of them who are not able to, for them the recordings are available. But the objective is to keep this information in public domain so that more and more people can access it and learn it. And of course, we are here to help you out, whatever help you need with respect to clinical pharmacy or pharmacy practice. Ma'am is here.
Yes, always all can approach, and you have any doubts regarding your family curriculum or regarding your MPharm pharmacy practice, I'm always available. You can approach and get it clarified. See, the only thing we wanted is the profession should be recognized by people, because you study the syllabus of what a doctor study, and yet we are not in the society the way what we have to be. So the aim is to uplift the profession. That is what it is mean. So we are there to help you at any time, whenever you can approach us also.
Absolutely, ma'am. Yes. So that is the only objective we have, to inspire people, to inspire the profession, to make the profession a better one, with knowledge, with capability, with talent, with resources. And everyone who has attended or registered for the session, they'll be receiving the LinkedIn link of ma'am, so that you can connect with her on LinkedIn as well. And in the same mail, you'll be also getting the recording of the session. And in case you have any specific questions with respect to clinical pharmacy, do write an email to me back, and then I'll discuss with ma'am, and definitely will try to respond it back as soon as possible. So thank you so much, everyone, for this learning journey. And I totally appreciate ma'am for her effort and the explanation that she gave. Mind-blowing explanation from her, and it was so much of learning for me personally today. And I hope this was the same case for every one of us who's attending this session from YouTube and also on Zoom. And those of you who will be watching it later on, please get inspired with whatever ma'am is doing. And pharmacy is a wonderful profession, and if there is some negativity, it is totally because of us, and totally because of some of us who are not so professional and renting out the certificates. So please do not rent out your certificates. A humble request from both of us today. And
yeah, please don't surrender. See, I always used to tell to even my students, you go to a physician, he's asking you, I want your MRI scan. Okay, get me once, and then if I don't have money, are any of us are dare enough to tell our physician, sir, shall I take half brain only MRI because I have 6,000? We won't tell that, right? You go to a pharmacy, Dodilla, I don't have money, give me only one tablet, we are telling. That is because we diluted our profession. See,
absolutely.
Doctors, they are not dare enough to tell that answer, but to us, they are dare enough to tell means, just a pharmacist. No, we are not just pharmacists, we are pharmacists. It's an emotion. It is not an English word.
Totally agree with you.
Not an English word. Pharmacist is not English word. It's an emotion. So that passion, if you don't have, there's no point in that, isn't it?
Absolutely, ma'am. Totally agree with you. So we have diluted our profession, and the onus of bringing it back lies on to us. So be responsible, be humble, and be professional. And I'm sure we'll have better days to come, and we'll be totally, proud to be representing our profession again. So thank you so much, everyone, for being part of this session. And we'll meet next Saturday again at 2 o'clock. The details will be shared on LinkedIn and the Telegram group if you're there. And we'll definitely meet again. So, ma'am, thank you so much. Thank you so much for your time.
Thank you one and all, and all for your interest. Thank you. All the best for all the perceiving students. Good luck. Thank you, sir. Thank you one and all.
Thank you so much, ma'am. So with your permission, ma'am, I'm